30-year-old man who has utilized some anabolic steroids and has a diagnosis of heart failure. Welcome, Joey Farrell. Hey, Joey.
Thank you very much. Thanks for having me.
Thank you for being here today, Joey. This is such an important opportunity for me, as I always talk about the safety of steroids, mainly for the cardiovascular system, to understand what has happened to you. And thank you. I saw you on the BBC news organization, and I made a subsequent post on that. And now we are here today. We've pulled this together so quickly. And I also have two friends and patients that are mitigated. These are two gentlemen that are in this world of ours that are very close to me over many years, that are actually in the powerlifting world and have done some steroids and have had a diagnosis of either low ejection fraction and or with heart failure. And with the grace of God and modern medicine, they've recovered. Now, they're going to be here today with us. I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances in this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy. But to open up this discussion, I have my Director of Affiliate and Global Relations of Testosteronology and my science administrator, Andrew DeCaro. Andrew, tell us about heart failure first, and then we're going to add the steroids.
Well, it's first of all, it really is a blessing that we're having Joey on this podcast, and that, the condition didn't turn a different way. So the heart is designed to pump blood throughout the body. So the body and the extremities receive blood and so forth, the brain and the organs and so forth. So in the case of heart failure, which is different from heart disease, which is a buildup of atherosclerotic plaque in the coronaries, heart failure is when the heart is a chronic condition in which the heart no longer pumps the way it should. Now, this could be either what we call diastolic heart failure, where this is where the heart can't fill, and because the chambers become thickened, which is notorious for left ventricular hypertrophy, or we have systolic heart failure, where the heart is no longer able to pump blood outward, and this is where the chambers become really stretched and thin. And so now, the way they gauge heart failure is by the ejection fraction, okay? And so usually anything that is typically lower than 55, we would sort of consider that mildly reduced. That means the horsepower of the heart, the engine, is not pumping blood as effectively as it should. It's weak, essentially. So now, what do we have that are current, since there is no cure for this condition, we do have, in modern medicine, we do have many treatments that could greatly attenuate this and manage this condition so you could still live, long life. And those are ACE inhibitors, angiotensin receptor blockers, beta blockers. Especially now, we have the cardioselective beta blockers that focus on the beta 1 receptors. We have diuretics, we have aldosterone antagonists, we have Entresto, which is a dual combination of sacubitril with valsartan, and then we have what is going to be probably the newest and the most popular is going to be our sodium glucose linked transporter. So your Farxiga, and your Jardiance, and so forth. So, yeah.
So thank you so much for that overview. So let's get right into this. So most people in the world that enter into heart failure or the early stages of heart failure are silent. They don't feel it. And number one cause of heart failure, where the heart's not pumping properly, is coronary artery disease. That's the blocked artery. It's called ischemic heart disease. Now, Joey doesn't have this. He's a 30-year-old man. What we see, unfortunately, in the steroid world, and it's irregular. It's not for everyone. You see some bodybuilders, we don't want to say names, but there are bodybuilders in their 50s and 60s that have appeared to skirt this. And then you have men, and again, this is more men than women, but it's going to happen to women too, but that if you expose yourself to X amount of androgens, not just tren and high levels of steroids, but the other drugs that are used too, right? The growth factors, right? The insulin, and just being so big, training so hard, you're going to affect the heart. Now, with Joey's case, he had a diagnosis that was so amazing, just reached out that he knew he was going to die, or they're talking about that. Tell us, Joey, tell us, first off, thank you for being here, your steroid history. When did you start steroids?
So I started taking steroids in 2014. I had been sort of bodybuilding naturally from 15, and it was just that jump. I, just decided to compete. Everyone that I was competing against was taking it, and it was pretty much. I saw that I had potential because I won the show, so it was like, right, okay, so if anyone's got the right to do it, I guess it would have been me. So I jumped on, and dosages wise and like what I use, to be honest with you, I would say on the lesser side in comparison to sort of my peers. Like, I've never really pushed it to the point of being like to 2 gram totals or anything like that. I think the max my testosterone's ever been to is 750. And that was for a short period of time. And normally I would be running it around 400 to 500. Primobolan, Mastron, stuff like that, 700-800 max. Obviously in prep settings in the early years, so like 2014, 2015, 2016, there was higher dosages of like the oral stuff like Anavar, Winstrol, and I did obviously run higher trend then. And that's when I was like 23, 24. But I actually had a period of time in between sort of 25 to 28 where I was still taking steroids, but I wasn't living the lifestyle that great. The dosages were just kind of sporadic, and I was drinking a bit of alcohol a bit when I shouldn't have been. I was smoking a bit of marijuana, and that was one of them things that, like, I probably should have, looking back, I probably should have been off the gear completely. And it was only sort of in the last, leading up to the diagnosis, the cycle I was actually running was actually pretty small. And as you mentioned a minute ago, I didn't have any I would have known it unless I'd gone to have blood work. I never would have known it was anything there. And yeah, I'm kind of lost with it, to be honest. That's kind of
so when did you, so you did steroids from 20 years old, and you're 30 now, right? So
yeah, so I've turned 31 now, but I was 30 at the time of this finding, just last year.
No, so tell me so you did, you're an IFBB Pro, congratulations, very impressive. Right. So your body is incredible. I mean, you guys, you can't just think you're going to take steroids and look like this guy, but these guys are competing amongst themselves at different levels in the world. Right. Yeah. So your body's incredible. We know the discipline is amazing. We know you have to take the drugs. And that's where it's just so painstaking. It's so heartbreaking for me. No pun intended. So you're on the drugs. You're not even on really that much. You're taking the regular steroids. Did you have, because again, this is open. Did you have COVID or the vaccine? Because I know everyone's going to want to hear about that.
Do you know what? So I did have a double vaccine. And in 2023, the year before this was found out, I had a really bad cough. I never found anything out, but I did have a really bad cough. And I had blood work done, and the markers that were high on my blood panel that alerted me to this heart failure, obviously last year, were high. So CK and CKMB and C-reactive protein. But I didn't go and have an echo done. I just came off drugs completely. So I actually took 20 weeks of 2023. I took off steroids completely. No CRT, no PCT. And obviously my test levels never came back. And I had blood work done and everything looked better. So I then jumped back on. So we're talking about sort of September 2023 to December 2023. I was ran a blast, and then it was only January 2024, so a month later, that I had the bloods that then alerted me to go check. So it was almost like an ongoing thing, but it all did stem from a cough, a horrible cough. And I thought it was COVID, but I was like, no, I'm fine, It's just funny that you mentioned that, because that's literally just come to my head.
Well, we don't know. So again, if the average steroid user would go into heart failure at 30, we'd all be gone.
Yeah.
So clearly there are some moons that have to line up. Let's just try to go into this for everyone. And thank you so much for being so powerful and for coming forward on this, because so many men are going to experience this and learn from this if we understand what the science is and what potential risks can be there. So, okay, tell us about how did you were short of, what were your symptoms that alerted that you got an echocardiogram, your first low echocardiogram? What were your symptoms in the weeks before that?
So the only symptom that I really had that I can like put my finger on was cramping, but it wasn't like the normal cramping that you would get. It was like, so when I would train, I'd do a set of curls, for example, and then when I would go to do my next set and I'd straighten my arm, I couldn't straighten my arm for a bit, right? That would happen. Then I'd have like a lot of sort of, I wouldn't even call it cramping, but spasms, especially in the front delts. I'd have that a lot, and it would go down into my legs. And the thing is, it was getting to the point where it would happen like every muscle group I did. About an hour after training, I'd get home, chest, I couldn't even open my chest up without having this cramp happening. So I actually went to go get the bloods, and like, the reason I was looking into it more is actually because I thought I had rhabdo at the time. And that was what someone had previously told me that potentially it was. And obviously then those markers were up on the bloods, because I was actually about to go into prep, full steam ahead. And it was almost like a precautionary blood test. I had literally put the cramps down to just my size and dehydration and electrolytes. So when we found the blood work that was bad, then I had the MRI, and that was when I had those findings. So it was like, wow.
How low was your ejection fraction?
So it was 39% on the left ventricle and 36 or 37 on the right ventricle. So LVF was 39.
The left ventricle. So you have a condition, they say, because we've seen the studies that you gave us, biventricular failure. So that's there's the right and left, right? Yeah. So it's interesting because most of this is usually the left side, the left heart failure, but you had biventricular. So it's just very interesting. But we have the other guys here. We do have some other guys here that have had similar. In the end, there's going to be some common denominators, then there's going to be not some common denominators. So again, so you present with heart failure. When was it? How long ago? So a year ago, they said, "Oh my God, you have heart failure."
It was literally this time last year. I had the MRI on the 14th of February. No, I had the results on the 14th of February, 2024, and believe it or not, in the UK, it was not. So we have the NHS, but I wasn't with a GP practice, so I was doing all the bloods myself with a company. And when I found the result, I signed up with the local GP, and they looked at the results and they didn't know what to do. They were like, right, you need to keep your heart rate down, your immediate cardiac arrest risk. We need to get you in for an emergency appointment. And that emergency appointment would have only been December just gone, so I didn't bother. I just dealt with it myself. So what? Didn't really have any mitigation to help it. I kind of just, with my coach's advice and a couple of like people I spoke to, I kind of like self-medicated, I guess, and just tried to lose weight and drop body
fat. For how long? Wait a minute. You had heart failure by an MRI or an echocardiogram or both?
MRI for the initial finding, and then I had an echocardiogram 16 weeks later whilst I was on prep. And there was massive improvements, but there was a couple of things that I don't really understand. For example, like the ejection fraction had massively increased. I'd come out of dilation from the right ventricle completely. The left ventricle was mildly dilated now, but then I had biatrium dilation, which I don't. That was in the initial MRI. There was no issue with the atrium size, so I didn't really understand how that contrast happened.
So technically, we have some things that are not related. I mean, you're looking at different studies. So, but did you ever have any ankle edema or shortness of breath or any kind of symptoms?
Nah, you know, I really didn't have like off-season body weight. Like you could say it was a bit of water retention. I mean, I
Yeah.
went to Mexico in December prior to those bloods, and I was carrying a bit of extra weight. Like I was about 120 kilos, and it wasn't clean. Like I didn't look nice for it, you know. So water retention, it wasn't like noticeable edema in terms of if I took my socks off, you would probably notice it. But if I took a progress shot, you probably wouldn't notice it. And I didn't feel
Right.
unfit really.
But so unfortunately you could not access a good cardiologist or internal medicine doctor. So what medicines did you use? How did you deal with this on your own?
So I essentially took some good advice from my coach, and another doctor in the UK that very probably similar, probably not on your level, but similar, who looks a lot more into the biology of with bodybuilders. And he basically said you need to reduce your dosages. So I did. I dropped my gear to 80 milligram a test, and I ran that consistently. I added 5 milligram of Cialis in the morning.
Wait, 80 milligrams of test?
Yeah, that's how low I went. That's how, to be honest, I looked right on 80 mig. I went so low because I was so scared, because I was only on 200 at the time of having the bloods to find out that I had the eco. So, and because the year before I'd come completely off and it didn't really do anything beneficial, I was like, I've got to stay on something. So yeah, it was too low. And at this time I was coaching myself because I'd left my coach and I was in the middle of trying to fix this on my own because I didn't think I was going to compete again. So it was 80 milligram a test. I ran 5 milligram of Cialis. I ran 80 milligram of Telmisartan, 500 milligram metformin pre-bed or with last meal. And that was pretty much it. And I did HIIT cardio every day.
And you lost, and how much weight did you lose during that?
I ended up coming down from like 120 kilos down to 94.
Wow.
I did a bodybuilding show in classic physique and I didn't do very well. And then I signed up with the guy who gave me the advice to do all of that is my coach, Darren. So I then signed up with him. So at the time I wasn't with him. He just gave me this protocol. I was at the Arnold Classic walking around and I basically said, can you have a look at this result for me? The doctors have told me you can't move. And I'm like, this sound right. So basically what happened was I'd done a show on my own. And then I was like, right, I feel good. I've done the show and now I'm going to get another blood test, see how things are. I'd done a blood test and the markers were just completely different. So I was like, wow. So then it was like, go and have an eco. So then I had an eco and it was so much improved. And then we went on a little bit of gear.
What is the echo improved and when was that?
So the echo was improved, which was 16. So that was in June. So it went from February to June, MRI, and then the echo.
Right.
Obviously my body weight was massively down. I was stage conditioned, but I was running no hardness or anything like that. And then 8 weeks after that echo, I won my pro card. So we haven't understood. So I want everyone to understand this, but we can go on and on and on. So where are you now? Where are you? How much do you weigh right now? Yeah, so now I'm back up to 110 kilogram.
110 kilos. And when was the last echocardiogram, your last ejection fraction?
So my last one was that one in July last year. So I've got one due now in 4 weeks' time.
Okay.
So disappointingly, I've had recent blood work again, and the markers that were high initially are high again. Some of them aren't. Like some of the stuff like Syriac.
What are those markers, please?
So the one that we found that was alerting me to my issue was the CKMB marker.
Right.
Now that is just somehow it seems to be like it just started to climb in 2023.
Are you doing a BNP?
BNP. I'm not sure what that is.
Yeah, brain natural. It's a classic marker that we use in the emergency room if someone comes in failure. It's very good assessment to understand what degree of heart failure someone's in, and then the rest of it is just a clinical diagnosis. All right, so now I'm gonna stop there. So you haven't had an echo. You feel okay. What steroids are you on exactly right now?
So now I just run 175 milligram of testosterone weekly. I run free IU of growth hormone pre-bed. I'm still running the Cialis, the Telmisartan 80 milligram. I'm running metformin 500 milligram pre-bed. I am actually experimenting with some SLU PP332 and injectable L-carnitine as a mix, and I'm also injecting glutathione daily as well, 200 milligram.
Okay. And your blood pressure, I know, is sometimes 140, 90, and sometimes you're labile. You're up and down on the blood pressure, despite despite the 80 milligrams of Telmisartan, and of course with the tadalafil is going to have an effect. All right, let's talk about this now, guys. So Andrew, you see, Andrew's my science guy. So this is where it's just amazing. We need to understand, all you guys out there. You got to get baseline, not just the lab. The CKMB is a marker that for breakdown of muscle, we like to use that old school in the emergency room, right? I know we'll say J, we got E and J. J, right? You're a nurse, right? Let's bring J into this. So you're a nurse and you're also a professional first responder somewhere in America. So you have experience with this, right? Let's talk about some of the history. You want to tell us your history? No one knows who you are right now.
Sure, it's fine. I guess we'll start. When I first started TRT, I must have been 36 or 37 at the time when I first started. And I think my first, I don't want to call it a cycle, but the first time I ever taken it, I think I did like 100 milligrams for a week for, I think, 12 weeks. That was my first powerlifting contest that I think I wasn't natural for. And then, unlike most people, I would always come off typically. I'd do a cycle for 3 months, 4 months. I'd maybe push it as long as maybe 5 months. I'd come off for 3 or 4 months. And then that was for like the first year and a half or so, 2 years. And then afterwards, I'd pretty much go around and take my 200 a week, almost exclusively year round. My doses, I never really pushed that high. I think the highest, when I was prepping for bodybuilding, at one point I was trying to do classic physique. I did 3 months of 300 cypionate a week. In the last 8 weeks of that push, I did 40 of Anavar a day. And then when I got into real prep, my dose of cypionate went up from 300 to 360, and then we added a Masteron 150 a week. The orals were out for a while. I was doing clenbuterol 40 a day, probably when I was 4 weeks into that cycle. And then right before I got sick, I was taking Winstrol, I forget the dose, 50 or 100 a day of Winnie before I ended up getting mild rhabdo and going to the hospital for dehydration. So
I remember
that prep. And then obviously I didn't really learn much, so I went back on TRT for the rest of the time, 200 a week. And the last meet that I prepped for, I pushed everything to only 300. And then there was a 2-week period before I got the echo that kind of led to all all the findings, even though I can talk about the other echoes that I've always previously had. But before I got put on days, I pushed to 300 cypionate a week, and then I was on 150 of Deca a week. But I only pushed Deca for like 2 weeks before I stopped that. Came off completely once.
You were heavy though. So one of the things, guys, one of the common denominators, despite the steroids and everything else, you were eating a lot of, you guys were both big. You were heavy, sir.
You're good. Yeah. When I was powerlifting, I peaked at the last meet of 222. Now, it wasn't like a solid 222. I was no pro. I mean, there was a lot of fluff for sure. I mean, I thought I looked great, but if you compare like what I look like now prepping for a new bodybuilding show versus then, it's day and night, obviously. But I didn't care. I was trying to lift this heaviest weight as I possibly could. So it didn't matter what I looked like. I just wanted to get big. I wanted to get strong. So yes, I was definitely way bigger than I am now. I think I'm down almost 50 pounds from where I was.
50 pounds. So
pretty close.
Well, so tell us, you got the echo. You had, so for the viewers, you had no symptoms.
I was asymptomatic. I had 0 symptoms whatsoever. The echo that they did, which kind of like caused concern. Now, I'm sure it was just the tech that was doing the reading. It wasn't even a doctor that did the reading, it was a tech, right? So we did this, physical for work. The tech said my ejection fraction was 40%. I was like, I know I've been low before. Like my last few echoes, the 3 previous years were 45 to 50. They always gave me a range. And the person said 40. I'm like, I don't know. I mean, I know I'm low. I don't think I'm ever that low. And then that's when the cascade of events all kind of started. Like, well, you may be in heart failure. It's, my cardiologist is always like, you're 45 to 50. It's a range, but it's normal for you. Like, you're fine. You're healthy. Don't worry about it. You're good. That's what they always tell me. And, because I had no symptoms, I had no reason to believe that he was wrong about anything. So,
all right. So before we go into I'm going to bring us, I'm trying to bring us all together here as we move through together as a group. Like Joey's the focus case. You guys are support here because you're recovered. Let's go to our next man. I'm going to call him E. So E, welcome, sir. Good to see you. No one can see you. No one's going to know who you are. We're going to mitigate your voice and your image. Can you tell us your story, please, sir? How old are you?
I'm 55 years old.
You look like a baby, though. Okay.
Oh, thanks. So 55, I've been on HRT and steroids for about 15 years. I powerlift. I try to powerlift. And I'm my favorite lab rat. So I will be honest about that. And I've done a lot of different compounds, usually not very high doses. Like the largest I've ever run is 500 tests, 300 deca. Usually I run my tests just a little bit. I'm scripted at 80 milligrams to 100 milligrams of HRT. Usually when I'm running something, I run my tests in the 100 to 200 range and then use other anabolics as necessary. And yeah.
What happened?
I really don't know. I've been training. Like about a year ago, I got sick twice, and I just assumed I still had the symptoms from my flu. I was short of breath, and I really didn't pay much attention to that because I got better. It had gotten bad enough that I couldn't have had this conversation I'm having with you guys right now without being out of breath. And like I said, I got better. Like it got to, I was training again. I was squatting heavy. I train in gear. I was training in gear, not having any problems there. But then sometime around July, I was sitting outside and I went inside and I fell. No idea what happened. I fell. So that's what made me go to my doctor. And they did an EKG on me and immediately sent me for a stress test. They refused to do the stress test on me at the cardiologist and did an echo on me. And their words were, "No one's ever told you have heart problems." And I jokingly said, "I bet I'm never going to be answer that question is no again." And they sent me on my way. And they're like, "Well, what should I do?" And I'm like, "Yeah, just keep doing what you're doing. Don't worry about it. We're going to get in touch with your doctor." So I did. I went and squatted heavy, doing rep work, 600 pounds for reps. I said, I'm a little out of it, but whatever. The next morning, I get a call from my primary care telling me to go home, do not work, do not walk up and down stairs. I'm a heart attack risk, and that I have an ejection fraction of 12, and that I'm a walking heart attack. And pretty much what made me go to my doctor besides the fall, I have an iWatch. I finally found it, and I put it on, and my resting heart rate was about 110. It would spike up to 120, 130, 140 if I was doing anything. If I was training, it would get up to 140 without doing any real effort. And I said, that's strange. So I'd sit and wait for my sets for my heart rate to get below 120. I'd do my next set. And I did this all in gear and never lightheaded, never lost consciousness. Like I said, my shortness of breath was gone by now, so I didn't think much about it other than I still had something viral going on with me. And that's what started everything.
You got an ICD inside you?
No.
Did they put you on a life vest temporarily?
No.
Okay.
No. The only thing I've had, they've put me on 24-hour and 7 and 14-day heart rate monitors to see if I was going into AFib, which is why I fell.
Okay.
And that's really it.
So now this is the amazing piece. Now we're gonna correlate together, going back to Joey, and you could see Joey he lost weight. You see that? you guys all lost weight, right? So, sir, E, I'm going to call you E.
Yeah.
Did you lose significant? So when I know you were on, we're going to talk about the therapies that,
Yeah.
right?
No.
But you did tell us.
I lost weight. Once I was diagnosed, all the symptoms showed up within a week.
Wow.
Like, oh, I'm out of breath. Oh, I can't walk without sitting down. Oh, I have no appetite. Oh, my legs are tingling. My hands are tingling. Up until they told me I had a problem, I didn't have a problem. And then I immediately stopped eating. I had no appetite. I was depressed. I was whatever I was. And I went from, I'm a little guy. I'm a heavy 200-pound guy. I'm 5'7". I was walking around about 205. I dropped down to 175, 170, something around that. And yeah, I did stop everything, including my TRT. But the weight came off before the drug stopped, to be quite honest.
All right. So let me go back to our other man here. So Jay, we'll call him Jay. So, sir, tell us the therapy they employed, because your heart's better now, right? Your ejection fraction 60, right?
Right. Yeah. So it went from that range of 45 to 50, and then it was probably a combination of things, right? So I lost close to 50 pounds.
50 pounds.
It's pretty close. So, like I said, I was 177 this morning. I was at 222. So, after that meet in July, I came off of everything. I stopped TRT. I took absolutely nothing, and I've been, no testosterone since then. So, not only did I stop the testosterone, I lost the weight. Just a ton of cardio, obviously. And then they started me on 80 milligrams of Telmisartan a day, and then also 10 milligrams of Farrell a day. I had to cut the Telmisartan in half, though, because my blood pressure was never high. Even at my heaviest, I wouldn't be higher than like 118, 116 over 60s or something. Maybe after a hard leg day, like maybe after a hard leg day, it would go up to like 120s over 70s, just temporarily. But I would just be resting pretty low. And then when I was on the 80 milligrams of Telmisartan, like I would tell, there's certain times of the day I'd have to get up slow from the couch because it would make me lightheaded. So I cut the dose in half probably 2 months ago. So I only take 40 at night as opposed to 40 twice a day. And I still kept the Farrell at 10.
Right. So, and you recovered on that. So, okay, guys, let's go into, there's some common things. There's steroids. We know Dr. Aaron Bagish. He's not a friend of mine. He's not really a colleague. I've worked together with him on a few patients in the Northeast. He's a cardiologist at Harvard, and he's interested in how anabolic steroids affect the heart. And anyone can look, and we're going to put some B-roll up here of Dr. Bagish's work. And this has been out there for at least 10 years. And so he talks about anabolic steroid induced heart failure now, or you could say cardiomyopathy. Now, there's no full etiology, guys. There's no single direct cause. There's going to be direct on the myocyte, on the cardiomyocytes, on the myocardial tissue. That's direct to the steroid itself, directly on the heart. Then there's indirect, right, with the RAS system, right? We talk about that renin-angiotensin aldosterone system. Now we're going in thinking cap stuff. Andrew, hold on. So, and then you look at the ABCs, right? Not to mention D. So if you're pre-diabetic or diabetic, probably doesn't play a role. None of you guys were pre-diabetic or diabetic, right? Because you're lean as shit and you don't have that issue. You're not obese. Your BMI is high. That is an underlying issue potentially. The overall BMI we know affects the heart and the kidneys. Next, the blood pressure, just sheer size. And not to mention, I know that you two gentlemen that were mitigated, you're powerlifters. And Joey, you're no joke. You're a big, strong man, but it's different. Bodybuilders and powerlifters, this is the underground brotherhood, right, guys? Coming above ground. We're brothers from different mothers, but remember, Joey, we make fun of you guys make fun of us and we make fun of you, right? So it's amazing. Like, we're powerlifters. You guys are these stupid, these funny bodybuilders in your little shorts, and we're just lifting stuff heavy. And come on, guys. So then you have guys like Ronnie Coleman who did both, right? I mean, lightweight. So look at this: the sheer size, the drugs of the steroids, but not for everyone. There's some underlying component. We know that the COVID vaccine is playing some role potentially. That's for all you guys. I'm going to say it. We're safe now. But yet we don't know. Not everyone with COVID vaccine or COVID is having heart failure or cardiomyopathy. Moons line up.
Real quick, guys, I want you guys to subscribe to my other YouTube channel, Testosteronology. My guy Andrew, who's helping me grow Testosteronology, interviews and works with all these other brilliant testosteronologists. You're going to see content on this channel about testosterone. Can it help men with sickle cell disease? Real pellets, testosterone pellets, and so much other great content. I want you guys to subscribe to Testosteronology YouTube channel.
So let's keep going with this underlying. You guys have lost weight. You guys have healed. We're going to talk about the pillars of heart failure that are for regular people, not steroid users. Andrew, let's talk about now the therapy. And Joey, I'm not your doctor, but I want to help you here. I want as millions and millions of people to hear this as possible. Spread this with everyone. You have to understand your health as even a young man or woman. It's going to affect your cardio and renal system. And you have to understand there could be other complications depending on your genetics for potentially having heart failure or congenital. Everyone's going to say, Doc, they must have some underlying congenital issue. Joey, do you have an underlying congenital issue, a heart disease at birth, or any heart problems ever in your life?
No, nothing. Nothing.
In all fairness to that argument that they will make, possibly, there are people such as, Dallas McCarver and so forth that do have ApoE polymorphisms that could cause cardiac issues early on. But now you put that on steroids, is what I'm saying.
But hold on. There's also there's hokum. There's hypertrophic guys. Again, I'm a doctor and I'm up there, right? I got to straighten this out from the gurus that I love, the gurus that I don't love, and I don't take the shit. So hokum. Can you have hypertrophic cardiomyopathy? I'm assuming you guys don't have that.
No,
You'd be dead. And you would have known it before, especially some of the healthcare practitioners that we have out there, right? So they know what they have. You got to get baselines. You have to really, and if your doctor says I'm not giving it to you, that's unethical. We're moving that. Go somewhere else. Let's talk about the pillars of care. Andrew, what are the 4 pillars of heart failure for someone who's not on steroids? And we're going to morph. We see that these 2 gentlemen have used some of those pillars and they're still on them today. Right? So let's talk about that.
Before I answer that, let me just dive in because I really want to quote Aaron Baggish here, because that study was really monumental for men on anabolic steroids, because the study did show significant reductions in systolic function, but it showed even more in diastolic dysfunction of the heart muscle, decreased contractibility and so forth, and reduced ejection fractions primarily in the men who were using anabolic steroids. And I will quote him right now. Quoting him, his exact words, I'm reading this, our findings of impaired cardiac muscle function was largely confirmatory by the magnitude of dysfunction and was higher than expected, and thus a surprise. This is the first report documented accelerating coronary artery disease and heart failure among anabolic steroid users. Okay,
right, so, and we're talking about heart failure, not coronary artery.
Yeah, I know, but they did bunch it together.
Right.
So, because it did cause heart failure, and it also showed that it accelerated atherosclerosis and so forth. They did this by CT angiography and 2D echocardiography.
If you guys watch this as young men, you may have to get off steroids, Joey, and stay on TRT with the grace of God. But I'm a career record, but we're not there yet, but we're getting there. Andrew, what are the four pillars?
So the first thing we're going to talk about is going to be the most basic, is going to be hypertension. Okay, because for one, when we when we use anabolic steroids or even testosterone, our kidneys now produce more renin. Okay, from the kidney. This is derived from the kidneys, and this causes us to retain more sodium. This causes for our vasculature to constrict, and this leads to high blood pressure. And this is now where the heart's now having to work harder, essentially, to pump. Now, also too, when we use anabolic steroids, we do have increased stimulation of what's called our beta-1 receptors. I'm getting a little bit deep here, but I kind of have to. Okay, so beta adrenergic receptors. Okay, think of like a lock and key. These are proteins that regulate blood pressure and circulation. What unlocks them is they're activated by catecholamines and such as adrenaline. Now, when we take anabolic steroids, these levels of catecholamines go up drastically, and the adrenaline goes up as well too. And now this now unlocks those receptors. Okay, so part of the pillars here is by using beta blockade, primarily through cardioselective beta blockers, we can essentially take a broken key, put it in that receptor, and so we could block those receptors from being unlocked. Because when we now have overstimulation of that going on, we now engage our cardiomyocytes that we have on our heart muscle. On our heart muscle, we have androgen receptors as well too. So it's not just about hypertension per se. So when this is all activated, we have cardiomyocyte proliferation. This causes the heart to grow. Now you add hypertension to the effect. It's like working a bicep, Joey. It's going to grow. It has the stimulus needed, and now it's going to grow. The same thing essentially with the heart. So yeah.
So all right. So let's keep going along the list. So the pillars are, Andrew was right on that. The pillars for someone who has heart failure. Let's look at those and apply those to Joey. And we can see these other gentlemen their doctors have used these. So you're going to have to use these. So number one is the beta blocker, correct? Now, beta blockers we're going to see metoprolol, and they're going to have cardavolol. Those are not, the cardavolol is a specialized cardioselective, metoprolol is not. I like nebivolol. You know that, Joey. I like nebivolol. You're on Telmisartan. You have to lose some weight. You have to come off steroids and stay on testosterone. Give yourself a break. You have to look at Joey, you have to, you're young. You could still be beautiful and jacked and strong. Bodybuilders, even powerlifters, it's going to give afterload. It's going to hurt your heart. Let's get through the heart period. Maybe you can come back completely, but you've already damaged your heart with biventricular heart failure. The studies I've seen on you, you're just, if someone gives you bad advice, I have to be the harbinger. I have to be the communicator to tell you the truth. If you want to live, I'm 60. I've been playing with steroids a little bit my whole life and be very fearful, and I've protected against the vector forces. You need to do this now. You need to get shrunken down. If anyone says, hey, take all these medicines that O'Connor says and stay big and strong and be a bodybuilder, it's bad advice. So I want you to shrink down, but stay. If they say get off testosterone, you can't. And that's not going to, it's a dose dependent variable. You don't need that much. You can be strong, get very, very lean. Look at the other man. Well, you actually can't look at the other man because we mitigated him. But these other guys understand that's a big piece. Lose the weight. Next, I would take the Telmisartan. I know your blood pressure is not well treated because the Telmisartan. We know you're nervous, and he talked about obviously the adrenal effects, but losing weight helps blood pressure. Now, if your heart rate is anything in the 70s or higher, you should consider adding a cardioselective beta blocker. So that's my combination. Nitric oxide, right? Great for sex, great for pumps, right? Great for the brain.
Endothelial protection.
And so this would be a great combination. But don't, every man in the world, just don't copy this. So if your heart rate is low in the 60s or lower, you can't take it. Like the one man here, every man's different. So, but if your heart rate's in the 70s or even higher, what is your heart rate, Joey? Baseline heart rate right now?
My rest, so Right now, as we're speaking, it's 75, but it's normally about 63, 64.
Okay. So you could probably tolerate a little bit of this Nebivolol.
Like
This is
5
up to
maybe.
you and your doctors. I love the combination because it's synergy. And again, it satisfies the pillars. Let's go next. The next one is mineral corticoid receptor antagonist, spironolactone, eplerenone. Now, you're so young. Again, these are not the pillars for you. There's no data for how to treat you. So you can see what I'm doing. We're looking at data from heart failure patients that you have that, but your etiology of the heart failure is not from coronary artery disease. It's not from obesity. It's not from smoking. It's multifactorial. It is in part from steroids. In part. Guys, you can't argue that. Common things are common. The vaccine is in there. The genetics are in there. You were just susceptible to it. These other men are true too, because these other men are kind of like you. They're not, you're younger, but they're not old and they're otherwise healthy. I know one of these guys had had hypertension for years, and there's some congenital support and his genetics, and by being bigger than his body is designed to be for years and years and years, it's a beautiful thing for us, gentlemen, but it could be destructive for your physiology. That's put all that muscle and all that mass. So the only thing you can do is take the ABCD approach, the blood pressure, the cholesterol, right? So looking at this. Next thing is looking at, again, the mineral corticoid. I don't think you should be on that.
I wouldn't think so either.
Your blood pressure is not going to be able to hold it. I think the Telmisartan with Nebivolol is going to be a big piece. And then the last piece is the sodium glucose co-transporter. Both of these gentlemen who have recovered, one of the common denominators of their recovery, Joey, is that medicine class. You need that medicine. And we're going to go forward and do research. Can we utilize this class of medications to prevent men that that are using steroids when they're on steroids and off steroids to prevent their heart? These two gentlemen both have come back. One of the most important features was beyond stopping and slowing the steroids down, losing weight, looking at the blood pressure, is they were on the sodium glucose co. But Joey, I don't want you to get this from underground sources. I want you to, you'll take this information and you'll go to a very good doctor. Are you going to a heart failure specialist?
At this moment in time, no, but that's why
a heart failure specialist.
Yeah, so that's why I'm getting this next eco now, and then like I couldn't get in. Honestly, I could not get into a cardiologist.
Oh my Lord!
Yeah, and that was what made me have to act as I did, and I didn't plan to continue competing. It was because it actually had that improvement. I thought I'll have one last spin, and then obviously I won my pro card, and now yeah, don't get me wrong, it's disappointing to hear like I won't be able to do bodybuilding. So I wanted to sort of do the pro thing, but at the same time, I understand that, like...
Joey, take a break, brother. Yeah. Look at these gentlemen. Look at these guys. These guys their hearts are back. Do you understand?
Yeah.
That's number one for you. You're 30-year-old man. You have to stop. You're going to stay on some testosterone. I'm not your doctor. This is not medical advice. But you're going to ease it down, do the cardio, do everything these men do, and you did. And I love that combination of medicines. And I want you, a doctor in the UK, reaching out right now. We're looking for testosteronologists. I want a doctor, a nurse, healthcare provider to take this man in your country. This is a shame on your country that this man has to wait. That's shameful now. Why would I want this man to have an expert physician or a nurse practitioner to help this man? And I just laid out the structure for the management plan. You need to be on that medicine because it's a healing medicine. Andrew, what do you want to wrap up with?
Well, I would say he's also, keep in mind, combined with the Cialis-2. And, you know, one of the, combined with the Cialis-2, I think that would really be, with the Cialis and the Vystolic, creating a combo, regulating us, the CMP and SGCA. I think that would really improve endothelial nitric oxide function. And when I say nitric oxide function, I'm not talking about taking an arginine-based drink. You know, Joey, we need like actual evidence-based medicines here. And I like that we saw an improvement, but you know, I got to be honest. An ejection fraction of 50, it's probably that of an old man, a 30-year-old.
You're too young, and you need
too young. You're way too young for this.
Everything you're on, you need a little bit of tweaking. You need to stay on testosterone. No heavy training, lose weight, get down, ripped and small. Soul search. Take it. Don't say you're never going to do bodybuilding or powerlifting. Don't say it for forever.
That's what's going to save your life. What he just told you just now, Joey.
You're not going to do it for today, but you could dream potentially. We have to get you through this dangerous time, because if you're so big and you're going back on steroids, you're going to guarantee to destroy your heart. You had biventricular heart. Sir, look at the studies. You're so young, you're using all the health reserve, and it's going to crash.
And now you slip back down into heart failure again. I mean, heart failure is a chronic condition. There's no cure. But you slip back down into the 30s again. These medicines might not work the same way they did before.
But I want you on one of those medications, and I'm not going to say the names again. It's sodium glucose cotransporter. You guys can look at them and don't
dapagliflozin and pagliflozin. Yeah.
Don't just get these off the damn guru internet, because now I know that everyone now is going to listen to me, and you're going to start to get this at your peptide site. That's bullshit. Now let's close with these two gentlemen that are mitigated. Can you guys close with any advice for Joey? E, you're first, E.
Let me think about that. It's, I miss my size. I absolutely hate it. I'm not going to lie about it. It's tough coming to terms with. I knew this time would come where I would be like I am now. I just didn't expect it to happen within 3 months. And that's probably the hardest part. I'm doing what needs to be done. And I value my life more than I do the size that I had, the strength that I had. And I'm following my doctor's advice, and things seem to be turning the corner. And I'm trying to reinvent myself and see what that is. So
absolutely incredible answer.
Wow.
That was very well.
This is a brotherhood, gentlemen.
Everybody needs to hear what he just said.
Let's hear from the other man here.
Yeah, I mean, it was. It's not going to be easy, because when they really wanted me to downsize, I was hesitant at first. I didn't want to lose my size. I didn't want to lose my strength. But then I was like, okay, what's more important? Being strong and winning medals that honestly no one cares about except for you. I get it. It matters to you. Or do I want my career? Do I want my health? I want to be around 80 plus years. And if you keep pushing and pushing, that's going to be tough to let your body. If you don't let it heal, then it's impossible. So, but it didn't take me that long to, I guess, and I miss being 222, but I look better now. I feel better now, even though I never felt terrible. And it only took 3.5, 4 months for me to get things back on the right track. I went from, a range from 45 to 50, and then I went up to 60. So it took me less than 4 months to get there, with cardio and losing weight and being on the drugs, obviously, and coming off of everything. I came off of everything.
So
right. All right, guys. So everyone, give us some I want you guys, all my guys out there in the world, please give positive comments always. We don't need the drama stuff. Please, men that are in the world that have experienced this, make some comments, make some noise. I think we could even get a podcast going in some special groups, and for the Testosteronology app. And I'm not here to sell my goddamn app right now. I want you guys to understand this. I want you to use your healthcare providers appropriately. It is kind of the world now of do it yourself to some degree of understanding, Joey. And you're actually in a highly developed country, right, if you will, and you are in a desert. So I want help on this. We need to turn the corner on this. Doctors and nurses, be kind to these people, because you don't think he's suffering. These men can suffer, and again, it includes women too. So Thank you so much, guys. So much. I hope we
Thank
can
you very
really
much.
help you guys with this.
Let me add, leave with one thing, then we'll bounce. But you know, we want guys to do bodybuilding. We definitely support bodybuilding, but we want guys to be to be healthy. We want guys to be strong too. We want to keep guys safe. We want to prevent people from dying. Because
And
Lord knows
honestly,
we've seen enough of it.
we can go on and on, but it's like
Yeah.
it's a dose dependent. Well, some of these guys don't. This guy took this dose and he had heart failure. This guy takes tons of drugs and he doesn't have heart failure. We don't understand all the mechanisms, but it's going to be man per man. Guys, keep the doses to a down low and look at your heart studies, ABCDs. I'm out. Thank you so much, gentlemen.
Thank you.
Thanks, Doc.